claims, clinical negligence claims, related to spinal infections in England. And our aim is to review the overall cost to the NHS of these claims, but also to heighten awareness of the condition, as well as the implications of delays in diagnosis. So working with NHS Resolution, we looked at all clinical negligence claims over an 11-year period to the end of 2019. Using their claims management system, we used these search terms and included all claimants who were adults at the time of the incident, whose claim concerned a delay in the diagnosis, and whose claim related to care in a secondary hospital setting. As well as this, we used the letters of claim for the successful claimants to identify themes within the data. So 41 claims were excluded as they did not meet this inclusion criteria, and of the 232 claims, 104 were open and ongoing, and 128 were closed. Claims were more likely successful than not, and 2/3 had damages paid. Within the 85 successful claims, 12 carried a periodical payment order, which means that as well as a lump sum, there's an agreement for an ongoing payment, usually on an annual basis. We use these 85 successful claims to identify the themes within the data itself. So of the 232 claims, the total cost of claims in all states was £278 million. This includes open and closed claims, as well as legal costs, damages, and predicted claims and periodical payment orders. When we put this into perspective and can compare it to cauda syndrome, over a similar 11-year period, there were 3 times more claims for cauda syndrome, but yet with an overall lower cost. And this figure represents claims in all states, as does the figure that I presented just then. So looking at themes within the data, the median age of claimants was 52 and 53 years, and the predominant area of involvement was the thoracic spine. Several patients presented with red flag symptoms and signs as per NICE guidelines. 55% presented with a fever, and it's important to note that not all patients had a fever or the classic triad of symptoms. And other common themes included that 29% had a recent history of other illness or infection, 24% had an invasive procedure in the last 6 months, and 67% had an uptrend in CRP level. Patients often presented multiple times before the diagnosis was made. 78% of claimants have presented 2 or more times to primary care. 73% have presented 2 or more times to the emergency department. And over half of claimants have presented 4 or more times before the diagnosis was made. We know that 5 have become tetraplegic and 16 have become paraplegic, and many of these had complete spinal cord injuries. We were limited in interpreting the neurological impairment for all claims, as not all letters of claim had the ASIA score, and also for any categories within the ASIA scoring system were prevented from reporting them if there's less than 5 claimants in due to data governance restrictions. Some claims had more than one cause of negligence, and there were causes of negligence at multiple stages along the patient pathway. Most common of these was failure to consider red flags, failure to consider spinal infection as a diagnosis, a delay in imaging, a delay or failure to discuss or refer the patient, and failure to interpret imaging correctly. So our recommendations include at least consideration of spinal infection amongst differential diagnosis of spinal pain and evaluation of red flags in all cases, a CRP evaluation in acute spinal pain, especially in thoracic pain, and in addition to NICE guidelines, we suggest a recent invasive procedure, a recent history of other illness or infection, and an uptrend in CRP should be considered as additional warning signs, especially in new thoracic and chest pain. So in conclusion, clinical negligence claims for spinal infections has resulted in a substantial cost to the NHS due to litigation, and costly mistakes occurred at a multitude of points along the patient pathway, and a greater index of suspicion and greater speed of action across all parts of the clinical care pathway is required. Thank you very much.
If anybody has any questions, can you make your way to the microphone?
Good morning. Thank you very much. So it's a great presentation.
Thank you.
So the number was 232, is that right? 232?
232 claims, okay. Open and closed claims.
Okay.
Yeah.
So I get the cost to the NHS, but my only concern, and just wanted to get your thoughts on this, so 232 on the iceberg of infections out there is not even a snowflake. You know, it's very small. So the problem with raising this as a potential spinal emergency is going to result in a flood of referrals to us as a spinal surgical team. And it's kind of like what's happened with cord equina. So we get referral after referral for query cord equina, and we're going to get the same problem. So I just wanted your thoughts on that. So I think in context, this isn't that big a deal, and the number of paraplegics was actually tiny.
Yeah.
So I just wanted your thoughts on that.
Yeah, that's an interesting point. I think one thing that we're working on with NHS Resolution now is looking at better access to MRI, especially in the emergency department. So if we can access MRI, or A&E clinicians can access MRI, then that should hopefully prevent the flood of referrals coming through to you if we can make the diagnosis first. I think the thing is that we just want people to be more aware of this condition is here and the implications that, you know, having a spinal infection can have in terms of the neurological impairment. So we do need to highlight that, but yeah, we do need to think about the implications it might have on the spinal surgery service. So I think, yeah, better access to MRI might help that.
One more question.
Sorry, can you hear me? Yeah, it's Rajat Verma. I work in Manchester. Interesting you say about the MRI, and something that is very up in my mind at the moment is because you've had several cases where the MRI scan was done, but the presence of infection was not recognized by the radiologist because of the system of radiology reporting in the UK. I think has taken a backward step. So I think just having an MRI, you have to find a way of having an effective reporting system.
Yeah, that's a good point. And I think one of the most common causes of negligence was failure to interpret the imaging correctly. So, yeah, that's a good point.
Lisa, can I just ask one question? It's been said that with spinal infection, because the cases are so complicated, particularly the ones that develop neurology, that as a medical legal expert, you can always find fault somewhere amongst the 200 to 300 pages of notes that you have to go through. Are you really talking about trying to manage infection better or trying to prevent negligence claims? Because the two things may be very different.
Yeah, I think it's more the latter, because I've looked at all of our spinal infection cases coming to the spinal injury unit, and actually once the diagnosis was made, the treatment and the management was actually very good. It's more the wait and the delay and the mistakes that were made, you know, them not making the diagnosis in a timely manner, that was the thing. And we find, and with this data as well, the thing that made people think of spinal infection was when they started to develop neurological deficits. And what we want to do is highlight this. We want people to have the diagnosis before the paralysis starts, really. So that's the main goal of what we're doing at the moment.
Yeah. Okay, thank you.
Thank you very much. Right, our next presenter is C. Youngfang, who's talking about can radiological factors predict outcomes in Asia A cervical spinal cord injuries.
Hi, good morning. I'm Pang, I'm one of the neurosurgical registrars working in Glasgow itself. So I did this project with the spine use unit in Glasgow, and the basis of this topic is to see whether there's any radiological factors that can predict Asia A conversion in spinal cord, cervical spinal cord injuries. I have nothing to declare, no potential conflicts as well. So we wanted to look at all MRI scans and CT scans of these Asia A cervical cord injury patients, and we want to find out whether there is anything on the scan that can help predict whether they convert to another Asia grade over time. This is a study done in a respective cohort. The reason why we chose Asia A cord injury is if you look at other studies being published, they tend to include all spectrums of Asia scoring. But we find that Asia A have the poorest outcomes. As you can see from this chart, about 30% that only converts. They have a low ceiling effect because, and also they have the most stable Asia grade that is unlikely to vary that much compared to Asia Bs and Asia Cs over time. So the way we carried out this study was I went and looked back at all the Asia A cervical cord injury patients, traumatic cervical cord injury patients in a spinal injury database. And I only took patients who had both a CT and MRI scan done. And we did the radiology measurements on PACS, and these measurements were only done by one person. The measurements that were analyzed are listed here: CT cross-sectional areas, lesion length on MRI, on T2 imaging and stir imaging, signal intensity on T2 and stir imaging, the maximal spinal compression on MRI, and maximal canal compromise on CT. We also looked at whether there was any presence of cord hemorrhage. We used the Pearson correlation coefficient as a statistical analysis tool for this. So these are some of the images of how I did the measurements. So on the left, you can see the T2 signal intensity ratio. Basically, what I did was I took the middle tree readings where the cord injury was and compare it as a ratio to the normal above and below the cord injury. And same thing with the maximum cord compression, the most compressed part of the cord versus the normal part above and below the cord. This is, on the left, is the intramedullary lesion length measurement that was done on both T2 and stir imaging, and as well as on the CT scan after reconstruction on MPR, we looked at the tightest part of the canal versus the normal areas of the canal and see what the ratios were. So what did we find? In this 11 years, we only had 58 patients that fulfilled the criteria of having both scans done. 48 of them were male. That's unsurprising given the fact that these are all traumas, and the average age was 55 years. 16 of these patients had at least one grade of ASIA improvements, and of which, interestingly, 4 patients had 3 grades of improvements. 19% patients had some form of surgery done at some point of time, and the average time from injury to MRI was about 3 days. The 2 factors that we found correlated with ASIA A conversion was maxillary canal compromise on the CT and also T2 signal intensity ratio. We found that there was no correlation between ASIA A conversion and the presence of surgery. So limitation with this study is, number one, it's fairly small numbers, and I think this is a reflection of the ASIA A patients, cervical cord ASIA patients aren't that many, despite this data coming from a population of 5.5 million, the Scottish population. You could potentially say that you could include the thoracic cord injuries, ASIA A's, as well as recruiting data from other units, but that would introduce some degree of heterogeneity in the sample. If you improve the quality of scans, probably you get more consistent measurements, and that would reflect more. But one thing I would like to see, personally, is earlier scans. If patients had scans within 24 hours of their injury, whether we would have more consistent and homogenized data to compare them with. So in conclusion, we found 2 independent risk factors that can predict likelihood of ASIA conversion. These findings are not only useful for prognostic purposes, but might benefit in helping surgeons select, which patient to go for to decompress early in the future. And I think more future studies need to be done to investigate this further. Thank you.
Any questions?
Yes, we have.
Hi, can I ask about your MRI scan? So your average time to scan was nearly 3 days. So are they all pre-op scans if they had surgery?
All pre-op scans.
Okay. It's quite a long time to get a MRI scan
Yeah.
for ASIA for 3 days.
Yes, and I think it depends on it depends on a lot on the culture of the unit that you work in. I've seen some units where they say yes, we need to decompress these neurologic deficits patient early, but some units prefer to, especially in the Scottish spine injury unit, they prefer to stabilize the patient and then wait before decompression occurs. And the MRI tends to be dictated by this more than the time of injury itself.
Could I just ask a question?
Yep.
Is the MRI time dependent? Does it change at times different from injury?
I think they do, because the amount of intensity you get on T2 and stir and the lesion length you get changes. And if you wait longer, I had 1 or 2 patients where they had, I think, 2 scans done because they deteriorated further. And you notice that the lesion length actually does increase. And if you if you look at other diseases, I've done in other studies before, you know that these lesion lengths can even regress after a period of time. So you want to catch them earlier rather than later. Otherwise, you generate a lot of heterogeneity in them, I think.
And the second and follow-up to that was, are you recommending or have you developed a change in the units that you've been working with so that they get CTs and MRIs early as part of their protocol for these?
I have personally not. I would love to do that, but I'm personally not, yeah.
Okay. Thank you very much.
Just another question, maybe not to you, but to people in the audience. Does BASCIS have any guidelines on timing of imaging and sequencing of imaging for MRI after spinal cord injury?
I'm not sure about
Does
that.
anybody,
I think there is.
any, no BASCIS exec?
No, from the BASCIS point of view.
Do you want to come up to the microphone?
My name is Naveen Kumar. I'm the president of the BASCIS. We don't have a guidance as such regarding to timing, but we would refer to the NICE CG54, which is the guidance of acute initial management of acute spinal injury guidelines set by the NICE, and it does recommend that the scan should be done ideally within 4 hours. And particularly for MRIs, for all those who have got any neurological impairment, so MRI is mandated. So we refer to or defer to the NICE guidance. Thank you.
Perfect, thank you.
Thank you.
Okay, moving on to, I'd like to invite Edward Dyson up to talk about clip closure of intentional dural tears. I do lots of unintentional dural tears.
We'll come on to that.
Thank you.
So I'm going to tell you specifically about intentional durotomies for intradural pathology and looking at the outcomes of titanium clips for closing them in our 2 centres, the National Hospital Queen Square and the Royal National Orthopaedic Hospital in Stanmore. I'm conscious that this may be something that a lot of you already do. If so, apologies. But the literature suggests a higher complication rate than our experience, which is why we thought it was something important to present. I don't have any conflicts of interest. Obviously, we need to obtain a watertight dural closure after opening the dura to remove tumour, remove arachnoid web, whatever it might be, to prevent future CSF leak through the wound, pseudomeningocele, return to theatre, which is costly, meningitis, which is potentially severely damaging to the patient. And the traditional way to achieve this is with a small, normally 5/0 or 6/0 Prolene suture. This has some disadvantages. Firstly, it can be quite time-consuming. It requires making a number of holes in the dura, and there is some evidence to suggest that leakage can occur through the suture holes. So our method is to use non-penetrating titanium clips. These are made by a company called Lemaitre in the US. It costs about £80 for a clip applicator, and we tend to use the extra large clip applicator and the 8 centimetre, not the 15. You see the 2 lengths there. The shorter one is normally adequate. And these were developed for vascular anastomosis originally, but they're also very useful, as you can see, in opposing the edges and everting the edges of dura. And these have been looked at in vitro, and both, this is in a bovine cadaveric model where they've been compared with monofilament and braided sutures and found to have significantly increased retention of water at multiple pressures, both physiological and supraphysiological pressures, and the clips are much faster to apply than sutures. This is another in vitro study looking at where the leakage applies as pressure increases, and we can see that they're better than using polyethylene sutures. And the largest existing series is from the UK, from Jake Timothy and colleagues, where they found a nearly 14% CSF leak rate using titanium clips, and that required some further intervention, whether that was suturing wounds on the ward or return to theatre, and also a slightly higher than one might expect infection rate, although only superficial infections really in that group. So we looked at 116 patients in 2 units, Queen Square and Stanmore, using at 3 to 5 millimetre interval titanium clip closure, and we looked at the complication rate, looking at both CSF leak during the hospital stay and at 6 to 8 weeks post-op follow-up, and adverse reactions to the clips and infection rate. The clips are applied, as you can see, along the dural opening. We used Eversil glue in most of these patients. We now tend to use Verisil glue because Eversil is no longer available, and the Medtronic Dura Repair patch, and then another layer of glue over the top. We looked at 38 cervical cases, 39 thoracic, 31 lumbar, and 8 sacral cases, most of those Tarlov cysts. And then within that, a range of pathologies, tumours, CSF pathology and functional pathology. And the complication rate, we found a single case in 116 patients of CSF leak, and that happened during the hospital stay. This patient was subsequently found to have, subsequently went on to have a wound revision and a lumbar drain insertion, was found to have increased CSF pressure as an underlying probable contributor, and subsequently required a ventricular peritoneal shunt. As part of the management, we didn't find any adverse reactions or hematomas, and a single infection, which was again a superficial infection. So for those of you that haven't seen it before, I want to share with you the technique. So this is a linear durotomy without a defect, and after completion of the intradural part of the procedure, the hitch stitches are then crossed over to opposing sides to oppose the dural leaflets at all levels before the clip applicator is introduced. And then, as I said, at 3 to 5 millimeter intervals, the clips are gradually placed along. And you can see this is, I think, a 90-second video, so the total dural closure time for a reasonably large durotomy is reduced to in the region of about 2 minutes, which is considerably faster than most people can suture it. And that's obviously got advantages to a surgeon at the end of a long procedure. Then, after the clips are applied, the Valsalva manoeuvre is performed. You can see there's no leakage through in between the clips, and obviously no extra holes in the dura. And then the dural patch is overlaid to check the size, and the glue applied in the patch and second layer of glue afterwards. There are a couple of sort of variations on the technique. So this is arachnoid sparing duroplasty, where you have a defect in the dura and you want to use a patch to add in. This is sped up for the interest of the presentation. So obviously it takes a little bit longer with the patch, but this is probably about 4 minutes in total to apply a patch with the use of the clips instead of, again, with the suture, typically taking quite a lot longer. Thank you. Is that it? I've got one other video which we don't need to particularly share. If there's difficulty getting the edges together, then a hook can be used at the end. I have no way of fast forwarding this, so I can ask if there are any questions now.
Was that your last video?
Yeah, we can conclude and say these are very useful for intentional durotomies, but it would be useful to see from the CLIP study, which the BAS Trainee Collaborative are carrying out at the moment, what the complication and return to theatre rate is like from clips in unintentional durotomies. And we also have quite a lot of experience in using them for that, and it's our preferred technique for those as well, but I don't have any videos. Thank you.
Again, do we have any people?
Hi, I'm Swaroop Shanbag from Cardiff. I wanted to ask if post-operative MRIs, do you have any difficulties with interpreting them because of the titanium clips or glue itself?
No, early on they had some difficulty convincing the radiologists that it was safe, but we don't any longer. And the amount of metal artifact is absolutely tiny. But I think that is it's a sort of consideration for a tumour on the dura itself, like a meningioma, but anything intramedullary or a schwannoma or something, then it wouldn't interfere with interpretation at all.
Thank you. A brilliant talk. I could have listened to this before yesterday's masterclass because I gave the talk on CSF.
I'm sorry I missed it.
CSF, that's okay. I did mention the clip application as a novel technique. There is a lot of literature on pediatric cases. Sharastani, 155 cases in Southern California, have described a very low complication rate similar to yours. Any of these cases pediatric or?
No, so these were all adults, like the lead series, and so I think this is sort of reaffirms that in both adults and children it's a safe and time-effective and low complication method.
Thank you.
Thanks.
Okay, thank you very much.
Right, and our next presenter is, the paper is Do Oncologists Get It Right? An Assessment of the Accuracy of MSCC Prognostication by Vinay Jansi.
Okay, good morning everybody. Thanks for the opportunity to present our work when looking at the accuracy of prognostication in metastatic spinal cord compression. So we've all been in that meeting, the MDT meeting, where we have a case with some visceral metastases, some non-contiguous metastases in the spine, and some epidural compression. And really we need to know what we're going to do to try and get on with this patient's treatment. And that often is the prognosis, which is a key part of that, to decide whether we should do anything invasive and what type of invasiveness we should be aiming for. And we have various tools available to ourselves already in terms of prognostication. So there's scores out there which look at various domains. This is the revised Tokuhashi score. There are some biomarkers for physiological parameters, so things like serum albumin, neutrophil lymphocyte ratio, platelet lymphocyte ratios. And I think in the NOMS framework and in an MDT setting, the oncological estimate is really important because oncologists tend to know the biology of the tumor and also new treatment lines that may be available, both radiotherapy treatment lines or pharmacological ones. So we decided to look at all of this and evaluate the accuracy of oncological prognostication for MSCC in our unit. And what the prognostic tools we use is the revised Tokuhashi score. We use the platelet lymphocyte ratio at presentation, so the higher that is, the worse the prognosis, and the albumin level at presentation, so the lower that is, the worse the prognosis, and obviously the oncologist estimate at our MDT meeting. So we did that by looking at a prospective database, so it was 24 months of data, and we did categorize the data into the Tokuhashi month categories, the 6 months, 6 to 12 months, and 12 months, although for the biomarker data, it was a little bit more difficult to do that, so we just used 2 categories. The cutoff values we used for the platelet lymphocyte ratio was more than 180 and albumin less than 3.5 for poor prognosis. And those were the statistics that we used. So we found we had 190 cases in that group. 86% of the majority were from solid tissue types and 13% were hematological. And there was a significant difference in the mean survival of those 2 groups. So the solid malignancies did poorly as compared to the hematological ones, as we may expect. So we then started to look at the agreement, so what was the agreement between the estimates and the actual survival. So the first table there just looks at the percentage accuracy, so how many percentage-wise were accurate. And you can see for that, the revised Tokuhashi seemed to be superior at 72%, but that was for solid malignancies. So for the hematological malignancies, that was really poor, so very bad as far as from a Tokuhashi perspective. We then did the kappa values, so this again looks at agreement, and a kappa value showing full agreement is 1, and a kappa value less than 0.2 means that there's little or no agreement. So the oncologists, you can see, and the Tokuhashi was reasonably the same. That would be a kappa value which would score them as fair agreement. But you can see for the hematological malignancies in particular, the revised Tokuhashi did very poorly at 0.07. So Tokuhashi is not good at a good agreement with actual survival for hematological malignancies. So platelet lymphocyte ratio again was not too good, and the albumin ratio again fair. And if you combine the platelet lymphocyte and albumin ratios, then again it gives you a fair agreement with the actual estimates. There wasn't very good correlation between the oncologist and Tokuhashi, so that was poor as well. And we did find that both revised Tokuhashi and oncology seemed to do better at less than 6 months predictions. So these cross tables give you that information. So if you look here, you can see that in the first table. So for less than 6 months, if the oncologist said less than 6 months, there was about 86% agreement, and that seems to drop off as the months increase. And similarly for Tokuhashi, 78% agreement. Even for platelet lymphocytes, again, there was a good agreement for less than 6 months, and there was less of a drop-off. But you've got to recall that this is for only 2 categories, not the 3 categories. We did some logistic regression just to try and look at various, combining various factors to see what was improved. And when we did the odds ratios on these sort of analyses, we found that when we looked at Tokuhashi with the platelet lymphocyte ratio and albumin ratios being normal, then the survival over 6 months improved, the odds of survival over 6 months improved, and similarly for over 12 months. So the odds ratio increased. So basically what we're trying to say is that, in conclusion, that no predictors in isolation were significantly superior. The oncologist revised Tokuhashi and albumin at baseline prediction of survival overall was fair. The revised Tokuhashi is useless in hematological lesions. Oncologists and Tokuhashi did tend to be fairly accurate at predicting less than 6 months survival for solid malignancies. And then if you combine the Tokuhashi with the platelet lymphocyte and albumin, it was fairly good at providing the longer-term survival groups, so more than 6 months and more than 12 months. So what we're trying to say there basically is if your oncologist or your revised Tokahashi says it's going to be less than 6 months, it's likely to be less than 6 months. If your revised Tokahashi says it's more than 6 months or more than 12 months, if you look at the platelet lymphocyte and the albumin ratio as well, and they also are normal, then it's likely it's going to be more than 6 months or more than 12 months. So using combined scoring predictors are probably better. Limitations is a single centre, so this did look at internal referrals only. We didn't capture any external referrals. The oncologists are all from one group, so you could argue that they're estimating poorly compared to other centres. The cutoff values that we use for PLR and albumin are variable in the literature, and obviously if we had bigger numbers, it would influence the results. Thank you very much.
Thank you, Vinay. Any questions? Okay, I'll start off. Nice try. I missed how many patients were predicted to be less than 6 months, because that's not a prediction I recognise amongst our oncologists.
Okay.
Was it a large proportion of your
no,
patients?
It wasn't a large proportion. No.
Yeah.
So the proportion with over 12 months was fairly small. So the percentage which was over 12 months was actually small. So most of the group was 6 to 12 months. But the less than 6 months it wasn't a large proportion. No.
Okay.
Yes.
We've got a question.
John.
Thanks,
Yes,
Ashley. Vinay, thanks. Great talk. I think I'm not the only one probably sitting here wondering what the platelet lymphocyte ratio is. I don't think I've ever looked at it. Could you just explain to us the relevance of that?
Yeah, it literally is that. So you look at the platelets and the lymphocyte count on admission, and you do the ratio. And there's one paper in particular for spine that says there's loads of papers looking at it for trauma, for cardiothoracics, for other malignancies. But for spinal surgery, there is one paper, which that one I referenced there, if you want to look at the Schoenfeld et al. And they showed that if the platelet lymphocyte ratio was above 180, then the survival at 12 months was low. Okay, and the albumin similar, 3.5 grams per deciliter or lower. The prognosis was poor at 12 months. Okay.
Any other questions? No? Thank you very much. Thanks, Vinay. And next presenter, Daniel Robinson, who's going to talk to us about the outcomes in spinal ependymoma.
Thank you. Good morning, everyone. I'm a medical student from the University of Manchester, and today I'll be discussing the outcomes in 39 patients who were treated for their spinal ependymoma in our centre, which is Salford Royal, and I was supervised by Mr. Mohammed Darija and Mr. John Leach. So, spinal ependymoma is a relatively rare tumour, primary tumour found in the central nervous system, and I actually struggled to find the incidence and prevalence within the UK. So this is a stat that was found within a US paper, which puts the incidence of 1 in 100,000. It accounts for roughly 2 to 6% of all central nervous system tumours, but about half of intradural spinal tumours within the adult population. And they're rarely found extradurally. Majority are found intradurally, and majority of our patients had intramedullary intradural ependymoma. So this was a single centre retrospective descriptive study of adult patients treated for their spinal ependymoma. As mentioned, the majority were intramedullary, so we looked at the ependymoma characteristics, so the location of the ependymoma, the histological grades, the patient clinical symptoms, the outcomes, whether they had a better functional outcome post-operatively, whether there was recurrence or progression of the ependymoma, the effectiveness of GTR, so gross total resection versus subtotal resection, and the use of adjuvant therapy, mainly focusing on radiotherapy. So as mentioned, 39 adult patients treated between 2011 and 2021, so the 10-year period, and I looked at the MDT meeting notes and the operative notes that was based on the EPR, the online system. The mean age was roughly 54 years old, and there was a fairly even split between male and females. So first, just looking at symptoms of pain was the most common symptom experienced by patients followed by paresthesia, and then weakness. And by far and away, the most common location of the ependymoma was in the lumbar region, and the most common grade was histological grade 2. There were about 8 patients with an unknown histological grade, and this was because a good number of them, 5 of them, were treated conservatively, so we didn't get a sample to classify the ependymoma, or there wasn't a note of the classification on the online system. So GTR was the most common treatment option, followed by STR, and as mentioned, only 5 of the patients were treated conservatively. And I think adjuvant therapy is a fairly controversial topic with regards to ependymoma treatment, and there's a lot of variety in the papers I've read as to the actual beneficial use of it. We can see only 6 patients were treated with radiotherapy, so the majority had neither radiotherapy or chemotherapy. So the overall 5-year progression-free survival was 87%. So now comparing the GTR to the STR, you can see that those treated via GTR had a slightly poorer functional outcome compared to those treated by STR, but this wasn't a significant difference. This may be due to the low number of patients in the study as well. However, we can see that those treated with the GTR had no progression or recurrence of their ependymoma, which can't be said about STR. Once again, this wasn't a significant difference, but it could be due to the low number of patients. So to summarise, our study shows that GTR is important in the treatment of spinal ependymoma due to its value for progression-free survival. In fact, as you can see, the progression-free survival was 100% in GTR compared to about 75% in those treated with STR. And there was no significant association noted between post-operative radiotherapy and functional outcome. And as mentioned, the major limitation to this study is the low number of patients. So perhaps we could sort of look at a larger cohort by doing multi-center studies, or sort of looking at a larger date, maybe going back another 10 years to get a larger sample size. And this study was also retrospective and a single-center study, so that also has its drawbacks. Thank you.
Could I just ask a question? Whether you were going for subtotal resection or gross resection, was that based on histology, morphology, or surgeon's choice? Do you know?
I'm not completely sure. I think maybe Khaled in the study could, in the
yeah, that's
audience.
probably a hard question for him to answer. It'd be based on the intraoperative appearances.
Fine.
Generally, yes.
That's, I mean, it's an area that I know absolutely nothing about, and I was just interested to know whether that was a decision because of low functional complications done preoperatively or intraoperatively.
No, and I think what the study helps with is it adds to what's already known, that you really get one chance with an ependymoma, and if you can, you need to take it all out. But on the other hand, if it's microscopically indistinct from the cord, sometimes your hands are tied.
Thank you. Thank you very much. It was a fascinating presentation.
In terms of series size, is this a large series in the literature?
So this is, from what I've read, this is sort of around the number that you'd get in a series. The other papers that I've read have been sort of multi-center studies, and I think the largest that I saw was around 100 patients for multi-center. So I think this is fairly substantial for a single-center study.
Fairly big size. And also I'd like to say very well done on the presentation. It's very daunting as a medical student to come to a meeting like this, but well done. Thank you.
Thank you.
Right, we have our last presentation done by Jack Penn on the surgical management of giant cervical paraspinal nerve sheath tumours.
Right, hello everybody. My name is Jack Penn. I'm a neurosurgery registrar at Queen's Square, and this is presenting a case series from the senior author Vittorio Russo. We're looking at giant cervical nerve sheath tumours with paraspinal extension. So no financial disclosures relevant to this presentation. So nerve sheath tumours are common. They represent probably the most common primary spinal malignancy, neoplasm, sorry. The schwannoma is by far and away the most common, apart from in cases of NF1. The schwannoma is typically a solitary benign lesion from the Schwann cells themselves. The histology of neurofibroma is a little bit more complicated and seems to be from multiple different cell lines. Most arrive from intradural nerve roots, with a proportion extending along the foraminal part of the nerve, creating this paraspinal mass, and there is a classic dumbbell appearance. Giant lesions are those over 2.5 centimetres in size, and especially when associated with paraspinal spread, they present specific anatomical difficulties. So there are lots of classification systems for NSTs. Most of them, well, originally in the 1940s, the Eden classification was used for a long time, but most of them are complicated and they mainly focus on the axial spread. Some of them look at craniocaudal spread and do volumetric analysis, but they're not widely used. And all of these have limitations for giant lesions with paravertebral spread. So our case series is 17 patients, which seems to be the largest that we can find. It's looking at lesions resected between 2016 and 2022. So schwannoma was by far and away the most common, followed by neurofibroma, and C2 was the most commonly affected nerve root, which is in keeping with the literature. Core compression was seen in over half of the lesions, but only 6 out of 17 were clinically myelopathic prior to surgery. There were no immediate complications. One case experienced deterioration of upper limb motor function, but this was transient. Vertebral artery involvement was common and was found in 14 out of 17 cases. It was typically abutting or narrowing. And there were a range of surgical approaches used, which we'll summarise briefly. Anterior, anterolateral, pure posterior, posterolateral, far lateral, and a combined approach. And fixation was in 5 out of 17 cases, and most of those were unilateral fixation for short segments, just 3 segments. So some of the considerations from an anatomical perspective when you're planning these operations would be critical vascular structures, top of the list, looking at the vertebral artery and the corticojugular bundle. You'd be looking at the extent of axial paravertebral spread, the extent of the intracanalicular spread and its relationship to the cord, be it in front of or behind the cord, and how it may have eroded or scalloped the surrounding bone. The cranial caudal spread, especially in these larger lesions, is sometimes a factor, and whether or not fixation is going to be something that you would plan for. So these are the surgical approaches, which I'll just briefly look at with you. So the anterior, or anterolateral approach, is good for control and mobilization of the V2 segment of the vertebral artery. A transverse scission by our team is based around the sternocleidomastoid muscle, and the dissection typically to take a retro-corticojugular passage, which takes us to the anterior rim of the foramen transversarium, which you can open up to liberate and mobilize the vertebral artery early in the course of the operation. And a clear visualization of the nerve root behind this will be achieved, and it can be combined with a further transforaminal approach to extend the opening and chase the lesion into the foramen. Here's just some pictures, just to give you a bit of a slightly less boring overview. So you can see the vertebral on the left side, the vertebral artery being released from its bony foramen there, and the exposure that you might achieve with the middle drawing, and then the axial diagram shows you that retro corticojugular bundle approach that we were talking about. Okay, which is. Now, if we go on to the pure posterior approach, so this is very familiar anatomy for most spine surgeons. A standard posterior approach with muscle strip and hemi or full laminectomy, depending on the intracanalicular spread. So partial facetectomy can be employed without any issues with regards to stability. And it's good for predominantly intracanalicular lesions, especially those dorsally based, and allows for confident, easy dural opening. So a posterolateral approach is really a variation on that, where it's a similar approach to begin with. A full facetectomy can be employed to gain a continuous view of the intracanalicular, foraminal and paraspinal spaces. And radical bony removal of all of the lateral mass can facilitate a very wide paravertebral view. It does have its issues with regards to the vertebral artery, which is not so easily visualized. Fixation should also be considered, especially if you're taking off quite so much bone as that. So here are some diagrams just to show you the idea of the amount of bone you might take away and the sort of view you might see. Far lateral approach is the last one I'll mention, which is typically for C1-2 lesions, those anterior to the dentate ligament. Allows for very good mobilization and control of the higher part, the V3 of the vertebral artery. Incision is behind the ear, posterior to sternocleidomastoid, through the muscles of the posterior triangle. We get an anterior retraction of the internal jugular vein, and this allows opening and control of the bony anatomy to free up the V3 segment of the artery, and then focus on the nerve sheath tumour. And just a very brief schematic there. So conclusions, they present anatomical challenges, but they are certainly surgically curable lesions with excellent outcomes. Multiple different anatomical compartments may be involved, especially if we're looking at that extraforaminal paravertebral compartment, but then also the intracanalicular component. And because of the size of these giant lesions, often you will get both of those involved, which is where knowledge of these different approaches is important. And care of the critical neurovascular structures is absolutely paramount, as is planning for fixation, but that's often not required. Okay, thank you very much.
Question?
Very good paper, thank you. I'm Kaushik Ghosh from Preston. I'm a neurosurgeon by background. So you didn't mention in your paper what was the extent of the resection. Did you go for total resection in most of them?
Yes, so we went for, it was gross total resection in all of the cases apart from one. So one of those had a small part of tumour, very, very adherent to the vertebral artery, and it was felt that it was not able to remove it, that very small part. There was a second case that it was gross total resection was achieved. There was some post-op imaging, early imaging, which thought there might have been a small residual, but then later imaging showed that that wasn't the case.
And what sort of complication did you encounter?
So there were very few, actually. So there were no immediate complications during surgery. Post-operatively, there was one transient motor deficit, which improved after a few months, and that's actually in keeping with the literature. I think part of that is also from the neural aspects. The most common nerve root was C2, which can typically be taken safely anyway without any major deficit being seen. So, and actually this is consistent with most of the literature, that probably from a neural perspective, because these are slow-growing lesions, there's a thought that because they're slowly compressing the nerve, maybe other nerves, even the eloquent nerve roots, are taking over the function from a myotomal perspective. So,
yeah, I mean, that's the reason I raised this, because in my practice, what I do, don't be aggressive.
Yeah.
And if it means you leave some tumor, that usually doesn't grow very fast. So you can get away. Interestingly,
though, if you're looking at the literature, there are several case series where they have very specifically resected eloquent nerve roots, both in lumbosacral region and in cervical region, and found, even by doing that, very, very, very low rates of deficit, actually. Yeah.
Good paper. Thank you.
Thank you.
Anyone else?
Any other questions? Thank you very much for your presentation, and I think that brings us to the end of this session. Thank you to all the speakers, and coffee.
And thank you very much for all getting involved and answering questions. It's made it a very easy session.